Have you ever paused, maybe smelling your morning coffee, and truly considered the intricate, almost invisible wiring that makes that simple act possible? Or, seeing a friend smile, feeling the sun on your face. It's really quite astounding, isn't it? There's just this astonishing level of hidden complexity right beneath the surface of these everyday things. Today, we're taking a deep dive into one of the most fascinating and, frankly, vital parts of your nervous system, the cranial nerves.
That's right. And our mission here really is give you a shortcut to understanding these 12, or maybe, as we'll get into, possibly even 13 pairs of nerves. These nerves emerge directly from your brain. We'll unpack their specific roles, trace their pathways, and really try to grasp what happens when these crucial connections, well, when they don't function correctly. This should equip you with a pretty solid core understanding relevant to both neuroanatomy and clinical practice.
And to give you that well-rounded perspective, we've pulled insights from a great textbook, Cranial Nerves, Anatomy, Function, and Clinical Insights, and also the incredibly comprehensive Cranial Nerves entry on Wikipedia. So yeah, you're getting a broad and deep look. Okay, let's unpack this then. So what exactly are cranial nerves? How are they different from, say, the nerves running down your spine?
Well, the fundamental difference is really their origin point. Unlike spinal nerves, which, as you said, emerge from segments of the spinal cord all along your back, cranial nerves arise directly from the brain itself, or the brain stem that's the part connecting the brain to the spinal cord. And they're always paired, one on each side. They primarily handle motor and sensory functions in your head and neck. But what's fascinating is some reach much further down into your chest and abdomen, controlling internal organs.
Wow. And what's really striking, you mentioned, is the sheer number and how specialized each one is.
Precisely. Conventionally, we talk about 12 pairs. They're numbered with Roman numerals, I through 12. And that numbering isn't random. It follows their order of emergence from the brain, basically front to back. Each pair has a specific name, a very distinct function. Some are purely sensory, just bringing information in. Others are purely motor, sending commands out. And some are mixed, doing both jobs. It's an incredibly precise setup.
Right, a real division of labor. And for those of us like me who appreciate a good memory trick, our sources even offer some mnemonics. To remember the names, there's, to touch and feel very green vegetables, AH.
Yeah.
And to recall if they're sensory, motor, or both. Some say money matters, but my brother says big brains matter more. Bit silly maybe, but they actually work.
They do. And, speaking of numbers, 12 pairs. This brings up a fascinating little twist. The mention of a potential 13th nerve.
A 13th? Really? Tell us more about that.
Yeah, it refers to the terminal nerve. It's often called cranial nerve 0, or CN0. Now, it's more recently been sort of canonized in human anatomy, and its exact role in us humans isn't fully clear yet. But it seems quite significant in other animals. It's implicated in some really primal functions, things like hormonal responses to smell, sexual response, even mate selection based on pheromones. It does make you wonder, doesn't it, if there's some unconscious, subtle function still operating in humans that we just haven't quite pinned down yet.
That's a perfect example of those surprising facts. Okay, let's dive into some of the most critical jobs these nerves do for you every single day, and importantly, what happens when they run into trouble. Let's start right at the front, smell and vision. That's cranial nerves I and II. First up, the olfactory nerve, CNI, your sense of smell. So if this one's damaged, no more coffee aroma.
Pretty much. Damage to the olfactory nerve, CNI, leads to what we call anosmia. That's a complete loss of the sense of smell. And you have to remember how much of what we perceive as taste is actually linked to smell. So if you lose your smell, food becomes very bland, maybe even taste distorted. It can surprisingly affect your quality of life.
I can imagine. Okay, then there's the optic nerve, CN2. This is all about vision, bringing those images from your eyes to your brain.
Exactly. And the key thing here is its very direct, dedicated pathway. The optic nerve carries visual info from the retina, passes through a specific opening in the skull, the optic canal, and heads straight for the brain. Now, this direct path means that if you get lesions, any damage or blockage along the way, depending on where that lesion is, it can cause very specific patterns of vision loss.
Like blind spots.
Exactly, but sometimes large ones. For example, you might get something called homonymous hemianopia. That's where you literally lose half of your visual field in both eyes on the same side, like looking through binoculars with one side blacked out. Or if the damage is at the optic chiasm, where some nerve fibers cross over, you might get bitemporal hemianopsia, losing the outer parts of your vision in both eyes. Tunnel vision, essentially. And inflammation, like optic neuritis, can mess with sharpness and color vision too.
Okay, moving on to eye movement. This isn't just one nerve doing the work, right? There are three working together.
That's right, a trio. The oculomotor, CN3, the trochlear, CN3, and the abducens, CN-ZERVs. They coordinate this incredibly precise control.
So how do they split up the jobs?
Well, think of the oculomotor, CN3, as the main workhorse. It controls most of the muscles that move your eye up, down, inward. It also lifts your eyelid, keeping your eye open, and controls pupil constriction.
Okay.
The trochlear nerve, CNIV, is more specialized. It controls just one muscle, the superior oblique.
Yeah.
Its job is that downward and outward rotation of the eye. Kind of a subtle but important movement.
And the last one?
The abducens nerve, CN the eye. Its job is to control the lateral rectus muscle, which moves your eye straight outward away from your nose.
So connecting this to the bigger picture, damage to any one of these must cause pretty noticeable problems, like seeing double.
Absolutely. Damage often leads to double vision, or diplopia, precisely because the eyes aren't moving together anymore, they're misaligned.
Makes sense.
And you can see other specific signs. With oculomotor damage, you might see the eyelid drooping, that's called ptosis, or the pupil might be dilated and won't constrict properly. With trochlear damage, looking down and in becomes difficult, so people might tilt their head, compensate, trying to line things up visually.
Ah, interesting.
And if the abducens nerve is damaged, the eye can't move outward, so it tends to drift inward towards the nose. That's called a medial strabismus. It's like the eyes are fighting each other for position.
Okay, let's shift to cranial nerve V, the trigeminal nerve. Now this one's mixed, you said, sensory and motor.
That's right. It's a major player. It handles sensation for pretty much your entire face touch, pain, temperature, and it also controls the powerful muscles you use for chewing.
And it has three divisions, covering different areas.
Exactly. The ophthalmic division covers roughly the forehead and eyes. The maxillary covers the cheek area, upper lip, and nasal cavity. And the mandibular covers the lower jaw, lower lip, and chin, plus those chewing muscles. And this nerve becomes really significant when we talk about facial pain.
How so?
Well, damage or irritation can cause conditions like trigeminal neuralgia. This is known for causing sudden, severe, almost electric shock-like facial pain. It can be absolutely excruciating.
Oh, wow.
But other things can affect it too. Shingles, which is caused by the herpes zoster virus, can affect a division of the nerve. Sinus infections, dental problems like abscesses, even severe headaches like cluster headaches can sometimes involve or irritate branches of the trigeminal nerve. It's kind of a central hub for facial discomfort.
Right. Okay, now let's look at 7-Up. These cover facial expression, taste, hearing, and balance. First, the facial nerve, CNZ7. What's its domain?
The facial nerve, 7th, is primarily motor. It controls most of the muscles of facial expression, so smiling, frowning, raising your eyebrows, closing your eyes tightly, all those subtle movements. But it also carries taste sensation from the front 2/3 of your tongue. And it has a parasympathetic role, controlling your tear glands and some salivary glands.
So it does quite a lot.
It does. And what's striking here is how relatively common problems with this nerve can be. Damage causes facial palsy or weakness. The most common type is Bell's palsy.
Ah, yes, I've heard of that.
Right. It often comes on suddenly, maybe after a viral infection, and leads to that characteristic drooping of one side of the face. Difficulty closing the eye, mouth droops, chewing can be hard. And also worth noting, it's the cranial nerve most commonly injured in blunt head trauma.
Okay, and its neighbor, CN8, the vestibulocochlear nerve.
This one is purely sensory. It has two distinct parts. The cochlear part, which is for hearing,
Okay.
and the vestibular part, which is crucial for your sense of balance and spatial orientation.
So if we connect this to potential problems, damage here would affect hearing and balance, right?
Exactly. Damage can lead to vertigo, that unpleasant sensation of spinning or the room spinning around you. It can also cause hearing loss or tinnitus, which is that persistent ringing or buzzing sound in the ears.
Vertigo. Isn't there a test for that involving water in the ears?
Yes, the caloric test. Putting cold or warm water into the ear canal stimulates the vestibular part of the nerve and normally causes specific involuntary eye movements called dystagmus. Observing those responses helps test the integrity of the vestibular system. It's quite a direct test.
Fascinating. Okay, next pair. CNIX, the glossopharyngeal, and CNX, the famous vagus nerve. These seem linked to swallowing, gag reflex, voice.
They are indeed closely related in function. CNIX, the glossopharyngeal nerve, has several jobs. It carries taste from the back third of the tongue, sensation from the pharynx or throat. It helps initiate swallowing, and it provides parasympathetic control to the parotid gland, one of your main salivary glands.
And the gag reflex.
Right. Both CNIX and especially CNX are involved in the gag reflex.
Hmm.
Damage to either can impair it, which is important because it's a protective reflex preventing aspiration.
Okay, and then CNX, the vagus nerve. You said this one gets really interesting, the wandering nerve.
Yes, vagus means wandering in Latin, and it truly lives up to its name. This nerve is incredible. It provides motor supply to muscles in your pharynx and larynx, crucial for swallowing and voice. It carries sensory information from those areas too, but its reach extends far beyond the head and neck. It provides the main parasympathetic control to your heart, your lungs, and most of your digestive tract.
Wow, all the way down there.
All the way down. It's like this major communication highway connecting your brainstem directly to your core organs. It influences heart rate, digestion, breathing, even aspects of inflammation and mood. It's central to that whole mind-body connection.
So damage must have widespread effects.
Well, isolated damage just to the vagus nerve is actually pretty rare because it's so extensive and somewhat protected.
Yeah.
But if it is affected, perhaps by surgery, trauma, or disease, you can see various issues. Autonomic problems like changes in blood pressure or heart rate. A hoarse voice is a classic sign. If it's branched to the larynx, the recurrent laryngeal nerve is damaged, and significant difficulties with swallowing, dysphagia, can also occur.
Okay, almost there. The last two pairs, CNXI or 12. Shoulder, neck, and tongue movement. Let's start with XEI, the accessory nerve.
The accessory nerve, CNXI, is primarily motor. It controls two important muscles, the sternocleidomastoid in your neck, which lets you turn your head against resistance,
Right.
and the trapezius muscle, the large muscle covering your upper back and shoulders, which allows you to shrug your shoulders.
So if that nerve is damaged,
You'd see weakness in those movements. Difficulty turning your head, especially against someone pushing back, and weakness in shrugging the shoulder on that side. A visible sign can be shoulder droop. Also, the shoulder blade might stick out. Particularly when pushing against a wall, we call that a winged scapula. It indicates trapezius weakness.
okay. And finally, CN12, the hypoglossal nerve. This is all about the tongue.
Precisely. It's almost entirely motor, controlling nearly all the muscles of the tongue, the intrinsic ones that change its shape and the extrinsic ones that move it around. Essential for speech, swallowing, and manipulating food.
So what happens if there's a problem here? How does that show up?
If you have damage to the hypoglossal nerve on one side, unilateral damage, the most characteristic sign is that when you ask the person to stick their tongue straight out, it deviates or points towards the side of the damage, the weaker side. You might also see wasting or atrophy of the tongue muscles on that affected side over time. And sometimes you can see these little involuntary twitches in the tongue muscle, like a little bag of worms wriggling under the surface. Those are called fasciculations.
Right, fasciculations. Got it. So we've mapped out all these nerves and their jobs. It's quite a network. But how does a doctor actually figure out which specific nerve might be causing a problem? You mentioned a neurological exam. What does that actually involve?
Yeah, it's a really systematic process.
Yeah.
It's not random guessing. It starts with just careful observation. Does the patient's face look symmetrical? Are their eyes aligned? Sometimes the clues are right there.
Okay.
Then the examiner goes through specific tests, usually in order, targeting each nerve or group of nerves. So for CN2, the optic nerve, they'll check visual acuity reading an eye chart and map out the visual fields, maybe by having you cover one eye and say, when you see their fingers moving in from the periphery. For the eye movement nerves, the 3rd, 4, and 6, they'll have you follow their finger with just your eyes, moving in all directions, watching for any lagging or double vision. They'll also check pupil responses to light for CN3.
Makes sense.
For CNV, the trigeminal, they'll lightly touch different parts of your face with cotton wool or maybe a pinprick to test sensation in those 3 divisions.
Yeah.
They'll also ask you to clench your jaw and feel the chewing muscles working.
Okay.
CN7, the facial nerve, is tested by asking you to make various facial expressions. Smile, frown, puff out your cheeks, raise your eyebrows, close your eyes tightly against resistance.
Right.
For CN8, the vestibulocochlear, they'll do a quick hearing screen, maybe rubbing fingers together by each ear or using a tuning fork. Balance might be checked by observing gait or specific balance tests, and maybe that caloric test if vertigo is a concern. For AXX, glossopharyngeal and vagus, they'll look at the palate rising symmetrically when you say, ah. Test the gag reflex carefully and assess swallowing and voice quality. Guys, accessory is tested by having you shrug your shoulders against resistance and turn your head against resistance. And 12, hypoglossal, is checked by looking for that tongue deviation on protrusion and checking for any wasting or fasciculations.
And you mentioned smell. CNI isn't always tested.
Not routinely. In a standard screening exam, no. Unless the patient specifically reports a change in smell, or maybe after a head injury where that nerve is vulnerable. If needed, they'd test it by having you identify common scents, like coffee or peppermint, with each nostril closed.
Wow, that's quite thorough. It really is like detective work, isn't it? Using these specific tests to pinpoint the source of the problem. So, what are the common things that actually cause damage to these critical nerves? What are doctors looking for as the underlying culprit?
That's a really important question because finding the cause directs the treatment, obviously. We can group the common causes into a few categories. A major one is compression. Basically, something is physically pressing on the nerve and interfering with its signals.
Like, what sort of things?
It could be increased pressure inside the skull generally, maybe from swelling or bleeding, or it could be a mass, like a brain tumor. For instance, an optic nerve glioma can press on CN2. A pituitary tumor, if it grows sideways into an area called the cavernous sinus, can compress several nerves controlling eye movement, 3, 4, 6, and also parts of the trigeminal nerve, V.
Okay.
We talked about trigeminal neuralgia. Sometimes that's caused by a blood vessel, an artery, pulsating against the trigeminal nerve root where it exits the brainstem.
Mm-hmm.
And another example is an acoustic neuroma. That's a benign tumor growing on the sheath of the vestibulocochlear nerve, CN8. But because the facial nerve, CN7, runs right alongside it, it often ends up compressing both.
Right, compression. What else?
Another big category is stroke, specifically an ischemic stroke, where a blood vessel gets blocked, cutting off blood supply. This can damage the nerve itself, or more commonly, it damages the nerve's nucleus, the collection of nerve cell bodies back in the brainstem where the nerve originates. Depending on which vessel is blocked, you get specific patterns of cranial nerve deficits. A specific, though rarer, vascular issue is cavernous sinus thrombosis. That's a blood clot forming in that sinus area behind the eye we mentioned. Because so many cranial nerves pass through there, 3, 4, 6, and parts of VL clot there can cause a whole constellation of symptoms affecting eye movement and facial sensation. It's an emergency.
Okay, so compression, stroke. What else?
Inflammation is another key cause. We mentioned Bell's palsy. That's thought to be inflammation of the facial nerve, CNDOA, often triggered by a virus. And then there are systemic inflammatory or autoimmune conditions. Multiple sclerosis, MS, is a classic example. It causes demyelination loss of the protective myelin sheath around nerves. And this can affect cranial nerves, often causing fluctuating symptoms that might involve vision, eye movements, or facial sensation at different times.
Right.
Rarer inflammatory conditions like sarcoidosis can also sometimes target cranial nerves.
So compression, stroke, inflammation, anything else?
Yes, a few other important categories. Direct trauma, especially skull fractures, can obviously sever or damage nerves as they pass through bony openings. Certain bone diseases, like Paget's disease, can cause abnormal bone growth that narrows the foramen of the holes in the skull, squeezing the nerves passing through them. And unfortunately, sometimes nerves can be inadvertently injured during surgery in the head, neck, or brainstem regions.
It's quite a range of potential problems. It really underscores how vital yet vulnerable these nerves are. Thinking about all this detail, it's fascinating to consider the historical context, too. How long have we actually known about these 12 pairs?
Well, our understanding has definitely evolved over time. Galen, the famous Greco-Roman physician back in the 2nd century AD, he only identified 7 pairs.
Only 7?
Yeah. Much later, in the 17th century, the English anatomist Sir Thomas Willis revised it up to 9 pairs. It wasn't until 1778 that the German anatomist Samuel Summering provided the description and numbering of the 12 pairs that we generally still use today. It took centuries of careful dissection and observation.
That really puts it in perspective. But you hinted earlier that the story might not be completely finished, even today.
That's right. What's fascinating is that the debate isn't entirely settled. For one thing, many nerves emerge from the brainstem, not as single trunks, but as multiple tiny rootlets, so there's always been some discussion about exactly how to group them. But perhaps more fundamentally, some neuroscientists still argue about the classification of the first 2, the olfactory, CNI, and the optic, CN2.
What's the argument there?
Because of their developmental origins and direct connection to the forebrain, structurally they look more like extensions of the brain itself, like brain tracts, rather than typical peripheral nerves emerging from the brainstem like the others.
Ah, I see.
So, while we functionally treat them as cranial nerves, anatomically, some argue they're technically part of the central nervous system, not the peripheral. It's a subtle distinction, but it highlights that our understanding is still being refined.
That's really interesting. So we've covered a lot of ground today. We went from the basics, what cranial nerves even are, through their specific individual jobs, controlling our senses and movements,
Yeah.
all the way to how doctors diagnose problems and the various ways these really vital pathways can be affected. It definitely makes you appreciate those simple things like smiling back at someone or just tasting your food when you realize the incredible hidden complexity making it happen.
Absolutely. And if you connect this to the bigger picture, I think the intricate design, the precise function of these 12 or maybe 13 pairs of nerves really underscores the staggering complexity of the human body. It just highlights how seemingly small disruptions in these pathways can have such a profound impact on how we perceive the world around us and how we interact with it. They're truly fundamental to our everyday experience.
Definitely. And maybe a final thought to leave our listeners with. Considering how our understanding of these nerves has evolved over centuries, from Galen's 7 to Soemmering's 12, and given the ongoing debate about classifying even CNI and I, what new insights, what further complexities might future discoveries in neuroscience reveal about these ancient yet absolutely essential parts of our brain? Perhaps there's even more hidden wiring we haven't fully mapped out yet.